So now we're going to look at some more sinus dysrhythmias or irregularities. Sinus dysrhythmia or sinus arrhythmia, you'll probably hear it called sinus arrhythmia more often because it's just easier to say. When you compare it, like so many other rhythms, to normal sinus rhythm, the only difference generally is the fact that the rhythm is irregular. If you look back from it from a distance like you are right now, you can clearly see how it is a little bit faster here, and then this segment slows down, and then it goes back to being a little bit faster here. That's the classic pattern of sinus dysrhythmia. So again, that's one of the major reasons why you start from the left and move towards the right. When we measure our regularity, you'll start here. You'll notice it's very regular here to here. Then when you go to here, it becomes irregular, never goes back to normal until about now. Then it goes back to regular again, then it gets a little bit faster. That's classic for sinus dysrhythmia. But even though the rhythm is not irregular, we can measure other complexes. So the second thing we're going to do is the rate. Because this is overall irregular, we're going to count the number of QRSs or R waves, and then times that by 10 within a 6-second strip. You can see the hash marks at the top of this strip. These are 1 second hash marks. So in between these two hash marks is 1 second. So that's 1, 2, 3, 4, 5, 6 seconds. That's clearly a 6-second strip. And I count 9 R waves. So 9 times 10 is 90. So the guesstimate or average heart rate for this particular strip is 90 beats per minute. I look at my P wave. Even though this is an irregular rhythm, I'm expecting my P waves to be very normal and alike. I see my P wave here. It's clearly not peaked. It's prior to the QRS and it's upright. Same here. Okay, so I'm marching it all the way across, and I notice that my P wave really doesn't change. It's a similar look, 1 for every QRS, even if it gets to the faster part and the slower part. I can measure my PR interval. I measure from here where it comes off the isoelectric line to here where the QRS goes off the isoelectric line, and that's about 3 millimeters, or 3 small boxes, so about 0.12 milliseconds, or 0.12 seconds. I measure that all the way across, and I notice that my PR interval is the same all the way across. Again, 3, you might see 3.5 small boxes. Either one is fine. When I measure the width of my QRS, again, I see that I have an upstroke coming off my T wave. My ST segment really is not involved because there's my isoelectric line there. But I can see where you might say, well, that's a millimeter depressed. It's okay to say that. But in this particular strip, you can say that it's about a millimeter depressed, but it's kind of iffy on this one. But my QRS is about 2 to 3 boxes wide, so 0.08 to 0.12. Then again, you could say that the ST segment is depressed. Some would argue that it's not. So this is one of those that's kind of borderline. When you look at your T wave, there's 1 T wave after the QRS. It's not peaked and it is upright, so it's relatively normal. So the only irregularity here, besides if you said a depressed ST segment, is the fact that the regularity is irregular. So when the only irregularity that's irregular is the regularity, then you're going to call this a sinus dysrhythmia, or again, you'll probably hear it called a sinus arrhythmia more often than not. The treatment modalities with this, if the heart rate is within normal parameters, we're probably not going to treat this unless, of course, the patient is symptomatic. If they're symptomatic, hypoxia symptoms are probably what you're going to see, and then we would give a medication either to speed up the heart rate or to slow it down, depending on what we're going to see. Most of the times, we're not going to treat this. This is relatively normal in children 12 years of age or younger, and we see a lot of adults with sinus dysrhythmia that have this dysrhythmia all their life and never need treatment for that. So again, in this case, if there's treatment, it's usually driven off the rate, and in most cases, it's going to be a slow rate that we're going to lead to treatment. If it's a fast heart rate, we may give something to slow it down. And just again, that's a very individualized type of scenario. When you see this dysrhythmia, the most common cause is respiration, so the act of inhaling and exhaling. When you breathe in or inhale, there's more pressure on the heart because the lungs take up more space, which is what we're seeing here. As the heart is relatively squeezed, it tends to beat a little faster. With exhalation and the relaxation that occurs when the lungs depress themselves, then the heart rate will slow down because it's less stressed. So that's usually what the cause of sinus dysrhythmia is, that it correlates with respirations. Okay, so that's sinus dysrhythmia. The last thing we're going to talk about when it occurs with the sinus dysrhythmias is what we call a sinus arrest and a pause, or a sinus pause. It's important for you to know that to say someone has sinus arrest, you're basically saying they have asystole. If you say someone has sinus pause, then you're giving me very little information. So with a sinus arrest or pause, if you truly have sinus arrest or you truly have sinus pause, you have to have an underlying rhythm to denote those two things, arrest or pause. Again, if you just tell me someone's in sinus arrest, which means this is all you're seeing, then that's asystole, and of course we need to treat that. We'll talk about that at a later slide. So to say sinus arrest or pause, think of that as an anomaly. So you have to address the underlying rhythm and then mention the anomaly. Very similar to if you have sinus bradycardia with ST segment depression. The ST segment depression is your anomaly. In this reference, sinus arrest and sinus pause is the anomaly. Now with this particular strip, I'll put this on here because it really clearly shows what we will determine in a minute to be sinus arrest, but it's very difficult to determine the underlying rhythm because when we look at these two QRSs here, we try to measure regularity, the distance between these two QRSs and these two QRSs are not the same. If they were the same, you could tell me what the underlying rhythm was. Because they're not the same, I would have to have a longer strip to determine what the underlying rhythm is. So for reasons of trying to determine what this is, we're going to call this normal sinus rhythm. Okay, it isn't, but we'll just call it that. So once you've determined the underlying rhythm, and on an exam, I will give you a clear one where you can easily determine the underlying rhythm. Once you've determined that, then you've got to address this anomaly. And this anomaly is either a sinus arrest or a sinus pause. What determines the difference is a sinus arrest means no electrical activity greater than 3 seconds in length. Sinus pause is no electrical activity less than 3 seconds in length. How do you determine the time frame? You go from the last R wave and you measure the time to the next R wave. If you were to count the big boxes, you would note that there's about 22 big boxes between this R wave and this R wave. 22 times 2.2 22 times 0.2 because these big boxes going horizontally is 0.2 seconds. 22 times 0.2 is approximately 4.4, which means 4.4 seconds. So this is clearly greater than 3 seconds, and I would call this a sinus arrest. So let's just assume for argument purposes this patient has normal sinus rhythm with sinus arrest. What am I going to do about it? It's very difficult to determine from one 6-second snippet of that patient's EKG rhythm as to how I'm going to treat this. If this patient has repeated episodes of sinus arrest, what's happening is they're going greater, in this case, greater than 4 seconds on a repeated basis with no electrical activity, which means we're having no circulation, and therefore hypoxia can occur in a cumulative aspect. On certain very unstable patients, that can be a very detrimental scenario. So again, to get a full picture, you would have to look at the EKG rhythms over a long period of time. But to see what kind of treatments, stimulation is typically what we're going to do. Wake them up, do a sternal rub, see if they can arouse themselves. If they are sedated chemically, maybe I have them too sedated, so I may decrease the amount of sedation and wake them up a little bit. There's multiple things you can do. The most common cause of both sinus arrest and sinus pause is sleep apnea. So again, awaking that patient, stimulating that patient, generally will make the heart kind of wake up. But again, one sinus arrest over a several hour period, I'm not going to do anything. Nobody's going to do anything. You've got to be logical and look at these things in a larger picture. So again, this is considered an anomaly, and treating anomalies will depend on what the big picture states. Okay, so the big thing is make sure that you tell me the underlying rhythm with a sinus arrest or sinus pause, and this is how you delineate them. Okay. So that's going to be the end of the sinus rhythms, and then we'll go next into the atrial dysrhythmias.